This is the topic on fibromyalgia. This is the way we're going to approach this topic. We're going to look at the definition, look at the epidemiology of fibromyalgia, briefly look at the diagnosis of fibromyalgia, a treatment approach to fibromyalgia. We're also going to spend some time looking at the new American College of Rheumatologists preliminary diagnostic criteria for fibromyalgia. And I'm just going to briefly mention chronic fatigue syndrome because during my reading on fibromyalgia I came across chronic fatigue syndrome quite a lot, and it's important just to get a handle of what the difference is because a lot of your patients are going to be having some symptoms from both. So, the definition. These are the things that you need to be aware of. It's a multi-symptomatic syndrome. It's chronic pain. There are multiple somatic symptoms. So these patients complain of a lot of things, a lot of different things. They don't have any inflammation or any tissue damage. And of course, because they complain of a lot of things, complain of a lot of different things, have many complaints, it's a heterogeneous syndrome. This is what you need to make the diagnosis essentially. So these are the things that are going to lead you to start thinking about fibromyalgia as a diagnosis. Widespread pain, widespread musculoskeletal pain. There's going to be widespread tenderness as well. When you put your hands on these patients, it's going to hurt them. They're going to have stiffness and or joint swelling. So this is something I didn't realize as well, but generally they can complain of stiff and swollen joints. They're going to be fatigued, they're not going to sleep well, and they're going to complain that they're not sleeping well. We ask patients if they sleep well, and then they tell us they don't, general pain patients, but these guys tell us they're not sleeping well. And it significantly impacts their quality of life and level of function. They're almost able to do nothing. Now the epidemiology is quite interesting. It occurs in females and middle-aged and older females. We know that. The ratio is about 7:1 females to males. But the interesting thing is it affects all ages, and it can affect young as well as old. It affects all ethnic groups and it affects all cultures. So everyone has fibromyalgia. All countries get patients with fibromyalgia. The rates seem to be increasing on the whole. Now this may be because we're diagnosing it more and we're understanding it a bit better. And the rates are also increasing with age, and that's interesting. The older the patient, the more likely they are to have fibromyalgia. So the diagnosis in 1990, the ACR gave us a diagnostic criteria. It all changed in 1990, where we became aware of the diagnosis following this release. So history and examination. History, you need spontaneous musculoskeletal pain affecting all 4 limbs, and it needs to be there for about 3 months. And then the examination requires tender points. This is not trigger points, these are tender points. Now trigger point may be in some of your patients and may be coexisting in some of your patients. And what trigger points are is they're taut, palpable bands of muscles that twitch when you snap and palpate them. And once you've diagnosed a couple of trigger points, it'll be easy to do so again. Fibromyalgia patients don't have trigger points. However, trigger points could coexist in these patients. The diagnosis, they have a number of other aspects that are coincidental in these patients and associated with fibromyalgia patients. So as I've mentioned, they're fatigued and they get non-restful sleep. High proportion of your patients are going to be depressed. High proportion are going to have anxiety, and a significant amount of them are going to have symptoms of irritable bowel syndrome. Chronic fatigue syndrome, as I mentioned before, and we'll give you the definition towards the end. And a significant group of these patients also going to have autoimmune diseases like rheumatoid arthritis, SLE and Sjogren's. From the diagnosis you can see it's a history and examination that leads to the diagnosis, so theoretically you don't need to do any investigations to confirm the diagnosis. However, it's important to do investigations in certain patients to exclude other things such as neurological abnormalities, renal and thyroid abnormalities, and don't forget about psychiatric abnormalities. You may need to consider causes of myalgia and investigate them for various causes of myalgias as well. Now, the pathophysiology, this all boils down to altered pain processing. So the way they process nociceptive input is different. And I've summarized this from a couple of articles into something that's quite easy to remember and hopefully to learn as well. But remember, it always comes down to altered pain processing. So there may be a genetic predisposition, and there have been some studies showing genetic polymorphism, for example, looking at COMT polymorphisms, so catechol-O-methyltransferase polymorphisms. There are three broad headings that abnormalities occur under, and there's abnormalities with the neuroendocrine system, abnormalities with the neurotransmitter system, and abnormalities with the neurosensory system. And a lot of the interesting and recent work is coming out in the neurosensory system. So let's look at neuroendocrine dysfunction. Changes in the hypothalamic pituitary axis and their hormones, so cortisol level changes, thyroid hormone levels change. There's been a reduction in growth hormones that has been associated with a number of these patients and found in a number of studies. And interestingly, growth hormones has been investigated as a treatment for fibromyalgia, but of course this comes with side effects. So neuroendocrine system changes. Something has been mentioned is called dysautonomia, which is an increase in sympathetic activity associated with a less of a response to stress. So let's move on. Neurotransmitter dysfunction, and this makes sense in that there is an increase in pro-nociceptive mediators in some patients and found in some studies. So the substance Ps, the glutamates, the growth factors. There is also a reduction in anti-nociceptive mediators, so the serotonins and possibly noradrenalins and dopamines as well. So these are a combination of what studies have found. Now the neurosensory system, and this is where the interesting stuff lies, it's an abnormality in the brain and spinal cord in processing pain. So hypersensitivity, so central sensitization, which we've discussed elsewhere. These patients display central sensitization. Their thresholds to pain are lower. They display wind-up temporal summation. Some patients have increased NMDA receptors, and NMDA has been associated with this. And that makes sense because NMDA is associated with central sensitization. A number of interesting papers looking at diffuse noxious inhibitory control, so the descending modulation changes and is not there in some patients. Functional imaging, a number of studies looking at functional imaging and how it changes in patients with fibromyalgia and how they process pain is changed in these patients. Some studies have shown reductions in new opioid receptors on PET scans, and even some studies have considered that there are some grey matter changes that occur in these patients. So you get an altered pain processing, and some patients also have a triggering event that leads them on to getting the clinical symptoms of fibromyalgia. I saw a patient that had a whiplash injury. She then presented with fibromyalgia down the line. So physical trauma, psychosocial stresses as well, and acute illness and acute sickness and acute hospital admission can sometimes be the trigger. Treatments. No cure. There is no cure for fibromyalgia, and at best treatment is modest. And this is the approach that has been defined by EULA in 2007, so a treatment approach. That's the European League. So what they say is a full evaluation of patients, and all this stuff is common sense to us, but nevertheless it's something that we need to do. Just don't focus on a medication, don't focus on one aspect. Evaluate them fully, evaluate the pain, evaluate the function, evaluate the psychology. Your treatment should be individualized. Again, this we should be doing for all our patients. Focus on intensity, focus on function, and focus on other aspects of treatments. So treat the depression, treat the fatigue, treat the other problems that they're having. Use your multidisciplinary team. Fibromyalgia is that one condition, or one of many conditions, that we should really be using our MDT teams to the fullest. And always remember, focus on non-pharmacological as well as pharmacological therapies. So the non-pharmacological therapies, and again, we know this, it needs to be multimodal. These are the approaches that you could, these are the non-pharmacological approaches that you could take, and we'll discuss each of them in turn. So exercise, a number of pretty interesting studies. They're looking at a number of exercises and reviewing a number of exercises, but it looks like aerobic exercise seems to be the best treatment or the best form of exercise for these patients. It increases muscle oxygenation, it increases muscle circulation. It also reduces inflammatory cytokines. So get them exercising, get them strength training, and get them doing aerobic exercise. Cognitive behavioral therapy works in a group of these patients, and it's been shown to change the affect, the cognition. We know that CBT gives them the tools to allow relaxation and stress reduction. And it's also been shown to increase the diffuse noxious inhibitory control, so it increases the ability for descending modulation on pain. Complementary and alternative medicine haven't been shown to be very useful. Maybe hydrotherapy and maybe acupuncture. Peripheral pain generators. Now I've put this in, it's not recommended by the EULAR official guidelines. However, it has, I'll just go back there, however, there are a group of these patients that have peripheral trigger points, musculoskeletal trigger points, and if you find them on your clinical examination, it makes sense to treat these muscular trigger points. Moving on to pharmacological therapies. Don't forget about the simple analgesics and weak opioids. They can be useful in some patients. I haven't found them to be particularly useful. Nevertheless, it's important to try them. Tramadol has been shown to be useful, particularly for pain flare-ups in fibromyalgia patients, and that might be because of tramadol's multiple mechanisms of action. Antidepressants are very useful in this group of patients, and there's a lot of level 1 evidence out there for the use of SNRIs in these patients. Antidepressants improve the depression component of fibromyalgia. It reduces pain, it improves sleep, it improves function and quality of life as well. So have a low threshold for getting your patients on these antidepressants. Tricyclics, level 1 evidence, use them and consider your side effect profile and your patients when you're prescribing tricyclics. The SNRIs, as I've mentioned, there is good level 1 evidence for SNRIs. The FDA has approved duloxetine's use for fibromyalgia, so it is getting used out there. And the NRIs, so the noradrenaline reuptake inhibitors, there are a couple of new ones out there. One of them is called reboxetine, and studies are looking into this. It might be useful. Anticonvulsants, as with the antidepressants, there is level 1 evidence out there for its use in fibromyalgia. And pregabalin, I think, has gained FDA. Yes, it has gained FDA approval for use in fibromyalgia. Now, the anticonvulsants don't work against the depression component, but again, they're useful, and it's all about multimodal pharmacological therapy. Interesting, I found an article on lignocaine where a one-off dose of 5 to 7 milligrams per kilogram shows some benefits, or thought it could be helpful in some patients without very serious side effects. Certainly doesn't form part of my treatment algorithm. Nevertheless, it's important to know that there are some odd studies out there. You're going to ask me about steroids and strong opioids, and the simple answer is no. Steroids haven't been shown to be useful in this group of patients, and strong opioids, the risks far outweigh the benefits. So let's move on to new preliminary criteria that have just recently been released. Now, what this is and I will appraise the positives and negatives, or advantages and disadvantages of this, but I'm going to just need to talk you through it. So you've got this table in your reading package, and you've got the reference as well. To diagnose fibromyalgia according to this new diagnostic criteria, patients need to have 3 of the following criteria. Although they need to meet these 3 criteria. They need to have a certain widespread pain index score and a certain symptom severity score. I'll elaborate in a second. They need to have the symptoms for more than 3 months, and there needs to be nothing else that can cause the pain. Now these are the two interesting things. The WPI, which essentially means that the number of areas that the patient has had that are painful within the last week. So it loosely correlates to the clinical tender points that you find that are found on examination. So you've got them there: jaw pain, chest pain, shoulder pain, leg pain, etc., and they then score between 0 and 19. Now the symptom severity score, this is a bit confusing, and I found it confusing when I first read it, but you score them for each of the 3 following symptoms: fatigue, waking unrefreshed, and cognitive symptoms, and you need to grade the level of severity over the last week, so between 0 and 3. So that you need to grade each of those symptoms. And then there's the fourth aspect, general symptoms, that you can grade as well. And if you have a look at the general symptoms, these somatic symptoms that they could present with that may give them additional points, you've got symptoms ranging from muscle pains, irritable bowel syndrome, to remembering problems, depression, blurred vision, diarrhea, itchy, wheeze, ringing, vomiting, heartburn, and the list goes on. And this just shows you how heterogeneous this condition is. So the new criteria, and this might be something that you may need to discuss to an examiner. They might choose to find out about what you consider advantages and disadvantages of the criteria. Advantages: the tender points are out, so those 9 symmetrical tender points, you don't need to have them or find them or diagnose them in this new diagnostic criteria. They bring about a new definition. They define the widespread pain index. They bring about a new spectrum, and this is the thing about the new criteria. It gives you a spectrum of fibromyalgia. It focuses us away from the signs and focuses us onto the symptoms of this illness. And really, using the new criteria, you can still diagnose them according to the old criteria, but use the symptom severity to define the severity of the illness. And because I've mentioned this is a spectrum, people can fall into and out of fibromyalgia depending on where they are in their disease pathway and treatment. We may capture more patients with these new diagnostic criteria. We don't actually physically have to examine the patients. Some physicians may actually accept this disease as a disease following the new diagnostic criteria. And I must warn you that there are some physicians out there that believe that fibromyalgia is not a true disease. However, the evidence is pointing to it. The evidence is gaining support or providing support for this diagnosis. But it's important to be aware of who you're talking to and how to go about talking about these diseases. This may improve research. It may improve the ability to deliver primary care to these patients out in the communities. And some say these criteria are simple. I don't know if they're really that simple, and maybe with repeated use they become simpler to use. So the disadvantages: you need to know your patients. That's one of the key disadvantages. It's going to be difficult to make the diagnosis on initial presentation. You're going to have a lot to get through, and you're probably going to take up your whole consultation just discussing the symptoms. So you need to know your patient. You need to take time to get to know your patient. You can't have a guess at the symptoms. And there's no clinical criteria for the diagnosis, as I've mentioned, and this may be a disadvantage. You need to examine all your patients anyway to exclude other causes and to gain a rapport with your patients. The disadvantage is only 98% of patients had 1 trigger point, and 96% had 3 or more trigger points. Sorry, I beg your pardon, tender points. You see, I've made that mistake that I don't want you to make. They're not trigger points, they're tender points. You need to exclude other comorbidities, so despite making the diagnosis, again, you need to examine, investigate if necessary. The symptom severity doesn't include mood, and this just made it too complicated. So this is a big disadvantage for these new criteria. It's not perfect. It didn't identify all the patients. It hasn't been validated in primary care, and it hasn't been tested with other rheumatological conditions. So more work is needed before this becomes the norm. Now, I just wanted to briefly mention functional somatic syndromes, because fibromyalgia falls into one of the functional somatic syndromes. Some consider it the key, most important functional somatic syndrome, because it's the one that's out there most. However, there are other syndromes that are equally as important. Now, somatic syndrome or functional syndrome is a group of symptoms. There's patients that have suffering, patients have disability, and there's no tissue abnormality. So if they've got those four things, really you can consider a somatic syndrome. And there are examples of somatic syndromes down there. The thing about all of those syndromes is no matter how heterogeneous they all have these following aspects. They are refractory to treatment, despite giving patients reassurance, explanation, and all similar treatments. It doesn't work. They reoccur with high rates. There's similar epidemiological characteristics, and they're higher than expected psychiatric comorbidity. So these patients have got depression, these patients have got anxiety, these patients have got OCD and other psychiatric abnormalities. Great book out there by the IASP on functional pain syndromes for those of you that may want to further expand your reading. There's some really interesting articles. One of the functional syndromes in this book was on cardiac pain. Really interesting read. I just want to briefly mention chronic fatigue syndrome, so you've got an idea of the difference, because your patients are going to be fatigued and it's important to know which is which. So I'll just quickly run through the definitions. Fatigue, it's temporary, it's relieved by rest. You have a long day, you're tired, you rest, you're okay. That's easy. Idiopathic chronic fatigue is fatigue that is new and has been going on for 6 months. So it's long-lasting fatigue. I'm just fatigued all the time. Now, chronic fatigue is idiopathic fatigue, so new fatigue, long-lasting for more than 6 months. But according to the criteria for diagnosis, you need to have 4 of the following. You need to have changes in cognition, so changes in thought processes. Unrefreshed sleep is going to be common. Sore throat, interesting. Tender lymph nodes, new headaches, muscle and joint pains. So that's the way you're going to diagnose and consider chronic fatigue syndrome. There's some other interesting reading on chronic fatigue syndrome in your reading package. It may not be entirely relevant to the exams, but it is relevant to being a pain specialist. That concludes this topic on fibromyalgia.